So Dr. Sammie Gill is a specialist gastroenterology dietitian. Many of us will know her from her time working at the BDA as their policy officer, but since that time she's undertaken postdoctoral research at King's College London, and she's worked in practice, but she now leads the scientific research and development team at Symprove. So a warm welcome, Sammie. Thank you.
Thank you very much, Amanda, and thank you to the Sheffield team as well for inviting me to talk today. It's very much appreciated. So today's talk will be on dietary fibre in gastrointestinal health and disease. And before I get started, I just wanted to talk a little bit about how the definitions of dietary fibre have evolved over the last 40 or 50 years. So going back to the 1970s, publications on dietary fibre were actually very few, so only around 5 publications per year. And at that point, dietary fibre was defined as plant polysaccharides and lignin that are resistant to hydrolysis by digestive enzymes. Fast forward another 10 years, and actually publications in dietary fibre increased exponentially, so around 300 per year. And it was these publications that then informed the 1991 Department of Health guidelines, which we're all quite familiar with. And at that point, dietary fibre was defined as non-starch polysaccharides, and the evidence was based on studies showing increased fecal weight with fibre and observations of decreased incidence of bowel disease with higher fecal weight. Fast forward today, and again, I know a lot of you here will be familiar with the 2015 Dietary Fibre SACN guidelines, which now define dietary fibre as all non-digestible carbohydrate with a degree of polymerization of 3 or more. And this was based, this was a huge review, it's a 400-page document of the research in the last 25 years, the majority of which came from prospective cohort studies. So the different types of fibre that's encompassed within that definition includes not just non-starch polysaccharides, so your cellulose and your non-celluloses, but also resistant starch 1 to 5, your oligosaccharides, so your fructans and your galactans, also lignin, which isn't technically a dietary fibre, but because it's so abundant within plant cell walls, it's included in that definition, and then finally polydextrose as well, which is a synthetic glucose polymer, highly soluble, non-viscous, and tends to be used quite frequently in the food industry. So when we look at the current body of literature around dietary fibre, it can actually be really quite challenging to apply the findings to clinical practice for a variety of reasons, which I thought I'd just skim through right now. So the first one is variations in interventions. So there's a plethora of studies within dietary fibre showing that synthetic fibres consisting of only one type of molecule is utilised. So for example, fructooligosaccharides, or extracted fibres from naturally occurring plant sources consisting of one or a limited number of fibres, so like alginate, for example, which is derived from seaweed, or something like psyllium husk. We've also got studies showing single foods containing a limited number of naturally occurring fibres that are intrinsic and intact in plant cell walls, so things like prunes and whole grain cereals and kiwi fruits. And then finally, we have our high fibre diets consisting of a wide range of naturally occurring fibres from a wide range of different foods. And so all these studies together and combined can make it incredibly difficult when we're trying to give that patient advice. Another confounding factor is the fact that high fibre foods and diets containing, they actually contain other nutrients, so vitamins and minerals, and also phytochemicals, for example, polyphenols, majority of which are non-digested and the gut microbiota ferment. And then finally, we have our in vitro and animal studies, which often use synthetic and extracted forms, so supplemented forms of fibre, whose actual physicochemical physicochemical characteristics might be different when consumed as whole foods, which then subsequently also affects the functional characteristics of dietary fibre, which I'll talk about now. So when we think about physicochemical characteristics of fibre, we're referring to things like solubility, so the ability of a fibre to dissolve in water. For example, soluble fibre has a high affinity to water, whereas your insoluble fibre tends to remain as discrete particles in a solution. We've got viscous fibres, and this is the ability for a fibre to form a gel. And we know there's a number of papers out there at the moment showing that actually viscous fibres can reduce glucose and lipid absorption rates. Then we have the fermentable fibres. So this is the ability for certain microbial species to hydrolyse chemical bonds within some fibres. And then finally, the food matrix. So how fibre is actually delivered and consumed will also influence its physiological function. So for example, with particle size, there's animal studies showing that with a small particle size, reduced particle size, there's an increased concentration of short-chain fatty acids, whereas human data shows that an increased particle size or coarse particle sizes like wheat bran can actually increase stool output. And this is simply due to the mechanical abrasion whilst it's in the gut and that delivery of water and mucus into the lumen. Now, all these physicochemical characteristics then determine the functional characteristics of dietary fibre. So, for example, micronutrient bioavailability. So, the short-chain fatty acid concentrations, or the increases in short-chain fatty acid concentrations that are associated with typical prebiotics, so fructans and galacto-oligosaccharides, have been shown to increase calcium absorption by increasing the solubility of calcium and passive diffusion across the intestinal wall. Some fibres may also increase absorption of water and fat-soluble vitamins. Equally, there are a number of studies that have actually shown the complete opposite, so the jury's out on that one still. At the same time, there's a number of compounds within dietary fibres, such as phytate, which we know reduce absorption of certain vitamins and minerals, for example, iron and zinc and calcium. Then we have gut transit time. So some fibres could potentially normalise whole gut transit time. And there's been some animal studies showing that, for example, fermentable fibres, it's actually the short-chain fatty acids that could potentially increase contractile activity via increasing abundance of excitatory neurons. Whereas the non-fermentable fibres, it's actually that increase in stool weight and stool volume that increase contractile activity. So it's very much dependent on the type of fibre, and the mechanisms are very different. Then we've got stool forming, so this refers to things like an increased frequency, improved consistency, or increased weight of stool form. And then finally, microbial specificity, so the ability for some highly fermentable fibres, particularly the prebiotic fibres, to change the composition of the gut microbiome and therefore functionality as well. So I just wanted to highlight the kind of concept around soluble and insoluble fibre, because I'm aware that we tend to use this quite a lot in clinical practice because it's also far easier from a patient perspective as well. But just to give a little bit of history. So soluble and insoluble fibre initially arose from early chemistry of non-starch polysaccharides, and these fibres were divided into two. Basically, those which have effects on glycemic control and also lipid absorption, so typically your soluble fibres, and then those which have a more pronounced effect on bowel habit, so your insoluble fibres. But just to give you an example here of glycemic control, I've highlighted here cellulose, which is an insoluble fibre, and then psyllium, which is a soluble fibre, but you can see that the way by which they affect glycemic control is very different, although they both do essentially the same thing. Solubility does not always predict physiological effects, and again, I've just highlighted here, you've got galacto-oligosaccharides here and methicellulose, which both have high solubility, but in terms of viscosity and fermentability, they're very different, which again will change the functional characteristics when they reach the gut. Whole foods are a complex mix of soluble and insoluble fibres, so it's not always particularly helpful to almost pigeonhole different foods as either soluble or insoluble. And actually, the terms around soluble and insoluble fibre were suggested to be phased out by the FAO in 2003, but like I said, and I'm aware that these terms are still widely used in clinical practice. So when we look at the research around dietary fibre specifically for health, there has been a plethora of research studies, particularly epidemiological, but also interventional studies, showing those important associations of fibre with the development and management of a variety of diseases and with mortality. So the first study on the left-hand side, or the first report, is obviously the second report, 2015, which highlighted that for every 7 grams of fibre from food, reduced relative risk significantly in a variety of different health conditions, such as cardiovascular disease, stroke, colorectal cancer, rectal cancer, and diabetes. Then Reynolds et al. In 2019 published a landmark paper, and this was a really prominent paper that assessed over about 185 prospective cohort studies and nearly 60 randomized control trials, and it totaled about 135 million person years. So it was really quite significant. And again, this particular study reflected the results of the second report, showing that relative risk is greatest when dietary fibre intake from food is between 25 and 29 grams a day. And it's these prominent papers that has led to actually most countries recommending a daily intake for adults of around 25 to 35 grams a day. Now, there are studies out there suggesting more is better, and potentially actually we should be aiming for nearer 50. But like I said, at the moment, the majority of evidence is suggesting between 25 and 35 grams a day for health. Now, moving on to gastrointestinal conditions and disorders, so the first one being irritable bowel syndrome. In essence, the guidelines very much vary, and this is where the challenge often lies. So, for example, NICE recommend reducing resistant starch, whereas the World Gastroenterology Organization recommends fibre-rich foods and or supplements. Now, if we look at the collection of systematic reviews and meta-analyses that have been published, they suggest collectively that some fibres are beneficial in IBS, but the caveat is that there is a wide variation in responses, as we'd expect. But the benefit tends to lean towards soluble fibre as opposed to insoluble fibre. Now, when we look at prebiotics, there is limited evidence for well-known prebiotics, like your inulin-type fructans and your galacto-oligosaccharides. And Dr. Bridget Wilson published a fantastic systematic review meta-analysis not too long ago on this very topic, which is a fantastic paper. Now, there are some candidate prebiotics that don't fit the technical definition of prebiotics, but they are a potential possibility in the management of IBS. Unfortunately, the research just isn't there yet. So things like pectin and partially hydrolyzed guar as well. And it's simply, again, down to due to those characteristics which I was talking about earlier on. So those soluble viscous fibers with a low fermentation rate. So overall, when we look at the guidelines for IBS-C and IBS-D, it's around recommendations of soluble fibre in supplement form, for example, psyllium husk, adjusting fibre intake accordingly, according to symptoms for IBS-C and IBS-D, and then obviously for IBS-C, we've got those ground linseeds, which are embedded within guidelines. Now, the BSG released their guidelines as well, I think it was about a month, 6 weeks ago now, and they suggested that soluble fibre, if recommended, should be commenced at a low dose, 3 to 4 grams a day, and build gradually to give the gut time to adapt and avoid bloating. From an inflammatory bowel disease perspective, there is continued debate on the clinical benefits of dietary fibre for this patient group, despite the plausible mechanisms. So, for example, production of butyrate and regulation of cytokine expression with some types of fibre, and those alterations in gut microbial composition. So if we look at IBD cohorts compared to healthy controls, IBD cohorts have been shown to have lower levels of bifidobacteria and also fecal bacterium prosnitziae, and which almost begs the question then, is this patient group essentially amendable with prebiotics? Now, I say one of the most prominent papers that has reviewed the evidence is a systematic review of RCTs by Wedlake et al. In 2014, and this involved review of 10 RCTs in ulcerative colitis and 12 RCTs in Crohn's. And as you can see from the results, 3 of the 10 studies in ulcerative colitis showed that fibre supplementation had a positive effect on disease outcomes, but it wasn't the case for Crohn's disease, suggesting that ulcerative colitis may be more amenable to fibre compared to Crohn's. And again, when we look at the overall evidence for inflammatory bowel disease, you can see the level of evidence is overall professional consensus. It's not based on hardcore evidence or RCT. So it's about encouraging a varied diet to meet energy and nutrient requirements. Consider limiting fibre and fibrous foods in patients with strictures. But dietary fibre should not be restricted unless intestinal obstruction. Because historically, it has been common in practice to recommend reductions in high fibre foods during relapse, but we need to remember this isn't actually evidence-based, so it's important just to monitor patients regarding tolerance to fibre during both remission and relapse. In diverticular disease, there is no consensus on the amount of fibre for management of diverticulitis. Typically, the recommendations are a low fibre diet during the active phase of diverticulitis to minimise irritation, followed by a gradual increase of about 20 to 30 grams, so in line with current dietary fibre guidelines for the general population. And it's also recommended a high fibre diet from mixed sources, so no one particular fibre or the other to prevent diverticulitis. Moving on to functional constipation, there's been several large cohort studies that have shown positive associations between high fibre intake and stool frequency, and a recent meta-analysis published a couple of years ago now showed that on 7 RCTs concluded that fibre, so wheat bran, psyllium, is effective in treating chronic constipation versus placebo. But again, there was very much emphasis on choosing the right types of fibre with the most appropriate physicochemical properties, if you like. So again, those soluble viscous fibres that retain their water holding and gel forming capacity. In terms of the recommendations, again, we've got meta-analyses here and RCTs in functional constipation, so encouraging gradual increases to minimise gastrointestinal discomfort, encouraging whole fibre foods with additional components with laxating effects, so for example, prunes and apricots, and a high-dose psyllium, so over 15 grams a day, has been shown to be beneficial in functional constipation. So in terms of the future of fibre research, there's this concept of fibre co-administration. So at the moment, it tends to be that single extracted or isolated fibres are used most commonly used to enrich fibre food products in the food industry. But it again begs the question, would co-administration offer more of a dual treatment approach by driving different functionalities? So incorporating those prebiotic fibres that might correct microbial dysbiosis alongside the bulk forming fibres that normalise stool output. And there has been very little research on this so far, but there was an randomised crossover trial in a small group back in 2004 showing that wheat bran plus resistant starch actually produced greater benefits in terms of transit time and fecal pH versus wheat bran alone. So there might be potential there. And then the other concept is looking at natural fibres. So, things like prickly pear or plantain peel or Nepal, for example, foods and plants that contain lots of different types of fibre and that hold those co-administration benefits, potentially have those synergistic effects because of the incorporation of phytochemicals and vitamins and minerals, etc., and those diverse functional characteristics for management of GI disorders potentially. So, in summary, manipulating and or increasing fibre intake is a promising therapeutic strategy in the prevention and management of many GI disorders. Physicochemical characteristics drive different functionalities in the gut and essentially underpin that therapeutic potential, so choosing the right dietary fibre for the right condition. Current guidelines reflect earlier studies that have used a wide range of dietary fibres with different physicochemical characteristics and functional characteristics, and it's this lack of consistency in reporting that has essentially limited the utility of dietary fibre in the management of gastrointestinal conditions. And there is an urgent need for well-designed RCTs to determine which characteristics and therefore which fibre sources in what doses and in what duration are optimal for clinical meaningful benefits for our patients. patients. And the utility of co-administration of different fibres with different physiological effects, or novel naturally occurring fibres with dual physiological properties, have yet to be explored but do hold promise as a potential therapeutic strategy across several GI disorders. Here are a couple of further resources which may be useful to you in practice. And I think I'll stop there. Thank you very much.
Thank you so much, Sammie. Thank you. And thank you. We do actually have a few questions via Slido, so thank you. Oh, except I've just defuncted my Slido. Could I start by asking the first question? One of the questions on Slido was, do you think some people who suffer from constipation have too much fibre in their diet? So that's an interesting question that's been posed, Sammie, for you.
It is, isn't it? Yeah, absolutely. Yes, absolutely. There is potential there, and I think it essentially comes back to the message of monitoring tolerance and adjusting accordingly, because every patient is going to be different, and so yes, there is no yes or no answer, but absolutely, yeah, I think yeah, there is potential there. Absolutely.
Thank you. And then a further question is, would you recommend people to take over-the-counter prebiotic supplements?
Honestly, I would say no. I don't think prebiotics are necessary. Again, it comes back to, if you're consuming a healthy, well-balanced diet, you're going to be getting prebiotics within your regular diet. I think the general recommendations are about 3 to 5 grams of prebiotics a day. And again, also by consuming whole foods, you're going to be getting a lot more in terms of phytochemicals and vitamins and minerals versus supplements alone. So.
Thank you. And in terms of the benefits versus the risks, so given the huge health benefits of having a certain amount of dietary fibre in one's diet, what are your thoughts about the fact that perhaps the traditional low FODMAP diet is perhaps lower in fibre than might be considered to be healthy for those health benefits?
Yeah, no, it's a really interesting point, and often why we tend to, with the low FODMAP diet, it's better utilised in those with, say, IBS diarrhoea compared to IBS constipation. And yes, absolutely. Sorry, what was...
Well, just your thoughts really, Sammie, in terms of, thinking of the wider health benefits of having a certain amount of fibre, but like you say, it's balancing up the pros and cons possibly.
Yeah, and also with the low FODMAP diet is a temporary diet, and obviously we don't want people to follow it long term because of those reductions in prebiotics as well. Yeah.
Thank you.